We see you every day. You take care of patients in every situation imaginable. You are good at what you do, but you always strive for better. Your time is valuable. That's why we are giving you Small Bites learning programs. You can learn a lot in a little bit of time, so let's get to it. Welcome to Cardinal Health Small Bites learning program. What's the difference? Pressure injury, IAD, and Candidiasis. Can you correctly identify pressure injuries, Incontinence Associated Dermatitis, and Candidiasis in your patients? This Small Bites learning program will help take the mystery out of telling the difference, and you'll get some management tips and tricks as well. First, let's make sure you know what we're talking about. Incontinence Associated Dermatitis, or IAD, is skin damage caused by exposure to stool or urine. You would expect to see IAD in a location that has been in significant contact with one or both of these effluents. Next, let's review what exactly constitutes a pressure injury. It is a localized injury to the skin and/or underlying tissue, and it's usually located over a bony prominence. They may also be caused by pressure exerted from other things like medical devices or other objects that exert pressure over time. And finally, candidiasis, or skin yeast infection, is typically caused by Candida albicans. Candida normally lives on the skin and inside body orifices. If it gets out of control on the skin, it can cause a rash. And if the rash goes unnoticed and untreated, the skin can become denuded and weepy. Now that you understand what the conditions are, what would you say is a common factor with all three? You've got it, moisture. The root cause of IAD is moisture from incontinence that sits in contact with skin. Incontinence is one of the primary risk factors for pressure injuries, and Candida thrives in moist, dark areas of the skin. So, when you are trying to correctly identify a skin condition, your first question should be, is moisture a factor here? Let's take a look at some photos to help get a handle on differentiating between these three conditions. What's your guess here? Are these wounds related to IAD, pressure, or candidiasis? Before you jump to conclusions, zoom out a bit to consider both the wound location and the patient situation. Is moisture a factor in this scenario? It is a safe assumption that the patient is incontinent based on the presence of an indwelling urinary catheter. The catheter prevents moisture from being in contact with the skin. There is erythema in the area of the wounds, so I wonder if fecal incontinence might be a causative factor. Since there doesn't appear to be skin irritation anywhere else on the buttocks, I can rule that out. Next, I'm going to consider the location of the wounds. This location is tricky for a lot of clinicians. Wounds like these often are referred to as buttocks wounds. However, once they are correctly identified as ischial wounds, then a cause begins to become more apparent. Answering a couple more questions will tell us what we need to know. First, is the patient at risk for pressure injuries? In this case, the answer is yes, the patient is incontinent, weak, and has limited mobility. Next, is there a source of prolonged pressure in the area? Location tells us what we need to know. The ischial tuberosities, or sitting bones, are significant pressure points when sitting, and if there's limited ability to shift weight while sitting, a pressure injury can develop. At this point, I'm almost certain that I'm looking at pressure injuries, but I need to consider the wounds themselves. Notice the shape of the wounds, circular with punched out appearances. The tissue in the wound beds indicate that they are full thickness, necrotic tissue in one, and pale granular in the other. So, when you look at the whole picture here, it is obvious that these wounds are pressure injuries. Besides appropriate wound management, a key component of this patient's care must be offloading the area by limiting sitting. I hope you are feeling like a super sleuth, because correctly identifying what causes wounds is as important as managing their care. Let's take a look at another scenario. This scenario can be a real head-scratcher. Let's take the same approach that we did with the previous scenario, and the root cause should become readily apparent. Even without knowing the patient's history, we can feel confident that incontinence is an issue. The wounds are widespread, especially when you consider the peripheral healed, apigmented areas. The wound margins are irregular. There are no focal, punched-out area that would indicate pressure injury like the wounds we saw in the previous scenario. These wounds likely resulted from moisture and friction associated with incontinent loose stools. Rapid transit stools are not only liquid, but often contain digestive enzymes. Frequent use of cloths to cleanse the area contributes to the development of IAD. If the IAD was caused by moisture and friction, then protection with skin barrier products and friction-reducing cleansing cloths will be key components of the management plan. Since IAD is usually partial thickness, the areas will be very painful. Anything you can do to protect will help reduce the patient's pain. That was pretty intense, but remember that once you understand the cause, the care is easy. Let's look at a final scenario. What's going on here? Looks like a widespread consolidated erythema beginning in the para area and extending down the inner thighs. Looks like macerated skin in the gluteal cleft above the rectum. And notice the satellite macular rash outside of the consolidated erythema. This scenario looks a lot different from the previous one, doesn't it? How about moisture? Macerated skin tells you that the wound has been exposed to significant moisture. The lack of open wounds and denuded skin is typical of skin exposed to urinary incontinence. So, is this IAD? The peripheral macular rash is more consistent with candidiasis, or skin yeast. Remember, candida tend to overgrow in warm, moist dark areas like those we see here. If we had the complete history, we would likely learn that the patient is complaining of itching in the area as well. It is not uncommon to find candidiasis after a course of antibiotics, since they can alter skin flora. So, while incontinence is an issue with this scenario, we would categorize this as candidiasis rather than IAD. Many times, skin yeast is mistaken for IAD and skin barrier products are applied. These products soothe the irritation and the rash may look improved for a short time, but the yeast will continue to thrive until appropriate antifungal creams are applied. Congratulations! We've covered a lot of ground in a little bit of time. Remember, the common culprit in all three scenarios was moisture. Managing moisture related to incontinence, then, is an important intervention when it comes to maintaining healthy skin. Cardinal Health offers products that are essential to care for prevention of pressure injuries, IAD, and candidiasis. You can use Cardinal Health's barrier creams to prevent and treat IAD. We offer several levels of protection, even one barrier cream with manuka honey, an ingredient known for anti-inflammatory and antimicrobial properties. For candidiasis, you can apply our antifungal cream to treat most common fungal infections while relieving itching, scaling, redness, and burning. You can fight the moisture factor with Cardinal Health's line of fully breathable briefs and underpads. You will breathe easy, knowing that your patient's skin is being kept cool and dry. Maintaining the right environment of the skin helps to prevent pressure injuries, IAD, and candidiasis. How about one more scenario to test your knowledge? This one will help pull together what you've learned. This scenario can be a tricky one, but you'll often face complex situations like this. Let's take the same approach that we did with the previous scenarios, and the root cause should become apparent easily. Even without knowing this patient's history, we can feel confident that there is incontinence, probably diarrhea. The wounds are widespread, even extending into the perineal area. Notice the irregular wound margins. They are not punched out, looking like the previous scenario. They are irregular, and there are bridges of skin between some of the wounds. This appearance lends itself to a scenario in which there is a skin exposure to an irritant, such as rapid transit stool, then friction from frequent use of cloths to remove it. How about pressure? Because the focal area of the wounds are not located over a bony prominence, along with other characteristics that we noted, there is a strong probability that these wounds are caused by Incontinence Associated Dermatitis, or IAD. Of course, if we had the patient's history to go along with this single photograph, determining cause would be easier. One other note that might be helpful to you: some of the apigmented areas are intact skin. When new skin covers an area, it is first apigmented. In this darkly pigmented skin, the pinkish white areas may be mistaken for open wounds when they are closed with apigmented skin. If you gently brush gloved fingers over the area, you'll be able to correctly differentiate between denuded areas and apigmented skin. Congratulations! You have learned how to differentiate between pressure injuries, IAD, and candidiasis. Thank you for learning and for being a skin champion. Check out more learning resources by visiting our website, cardinalhealth.com.